Tēnā koutou katoa, ko Tracy tōku ingoa, he kai tohu tohu hauora tui hono mō mate pona pona Aotearoa ahau. My name's Tracy and I am the online health advisor at Arthritis New Zealand. Very excited that we have Natasha on tonight, who is a patient who has undergone bilateral hip replacement surgery. And we have Dr. Simon Young. He is an award-winning orthopaedic surgeon specialising in knee surgery at the moment, but he has worked and trained in New Zealand, the UK and USA, and completed a sports medicine fellowship at Stanford University, where he provided orthopaedic care for the San Francisco 49ers NFL team and a Stanford college football team. He does have extensive experience in hip replacement surgeries too, and he will offer his clinical perspective on the surgery and recovery process. So we are going to start with Natasha, and she's going to talk a bit about her journey. So some of you might recognize Natasha. She's worked with us before. She did an awesome breathwork event with us in October on World Arthritis Day, and she was diagnosed with autoimmune arthritis at just 10 years of age. But she's going to tell us a little bit more about what she has gone through.
Kia ora, everyone. As Tracy mentioned, I was diagnosed at 10 with juvenile idiopathic arthritis. And pretty soon after that, underwent some steroid injections in most of my joints. It came on quite aggressively. I say that although I felt sick for many years prior. It came on quite aggressively when it finally hit the joints and they all swelled up. So I had some steroid injections and went swiftly on to methotrexate to control the symptoms. And by age 14, it was relatively in remission. And I managed to live quite a very normal teenage life from 14 to 18 with no medications and just being a very typical standard teenager at school, doing lots of sports. At 18, it did come back. I moved to Wellington for university, and stress is definitely one of my main triggers, and that massive change, along with some other lifestyle things that were going on, caused another flare-up and the symptoms to return. So then I started my journey again with a rheumatologist down in Wellington and went back on to methotrexate to start with, and again started having some steroid injections. And from the get-go, from 10, it was always mainly my knees and hips that were affected. And when it came back at 18, it seemed to just be the hips that were really effective, with some other joints swelling up from time to time here and there, depending on what I had going on. I continued studying and staying at uni and went on to medications, which once again kind of controlled the symptoms, but I kept needing steroid injections, especially in my left hip, and x-rays were already showing then that it was getting quite close to bone on bone. But with exercise and healthy eating and lifestyle intervention, I managed to continue on just by having steroid injections twice a year in that hip. By the time I hit 27, I was in Melbourne by this time. I was limping quite severely with putting all my weight onto my right leg, and it was then that I saw my first orthopaedic surgeon in Melbourne, and she told me that I would need a hip replacement, and that was my only option to deal with this pain and to be able to live a normal life again. That was hard news to take at 27. I don't even think it's hard news to take at any age, but at 27, when I feel like life's just beginning, just figuring it all out, to be told that I needed surgery. And at that time, I also had osteopenia, so my bones were thinning. And this particular surgeon said, due to how it was in the hip, I would have a really hefty recovery, and I'd be on crutches for 6 months, and this just didn't sit right with me, and it was the first surgeon I saw. And alongside at this time, I also met quite a few holistic practitioners and started working with them, and met a really good specializes in functional movement and Pilates, but in particular with injuries and rehab. And I started working with her, and I found that I could actually start to walk again on my left hip. And I was like, okay, maybe I can push this surgery out a little bit. And that started my quite alternative journey, instead of taking the surgery at that age, to what else can I do to delay this as much as possible? What else? I mean, at the time I was definitely in denial, and part of me was like, what else can I do to heal this? Maybe I can Joe Dispenza my way out of this. Maybe I can diet my way out of this, and all sorts. But it took me on a journey to Thailand. One of my teachers that I'd met in Melbourne, he was a breathwork facilitator, and I'd gotten quite a lot of relief from breathwork, meditation, yoga, and movement. So I went over to Thailand. He owns a healing center there, and I ended up studying with him. So I studied breathwork and yoga therapy, body work, and all sorts of different things to try and help the hip. And I actually did manage to get it into quite a good place where I could walk again, and I could even hike again. So I could hike about an hour or two, not my usual like day hikes that I love to do, but I was like, I'll take an hour and two, based on I was limping before I went to Thailand. And then I ended up staying in Thailand for 2 years, working with my teacher and helping other people going through chronic pain and autoimmune conditions, and really working on things like my mindsets, my mental health, my physical health. Got back into like learning all about like healthy nutrition, and yeah, breath work, and of course being in the heat and being right by the sea where I could get in the sea every day for rehab, for moving my hip, was super beneficial. Towards the end of my stay there, I got dengue fever, which if anyone's had that, it is not a nice walk in the park. And with autoimmune arthritis, viruses can again stir up symptoms. And by this time I'd been off meds again for 2 years, and I'd been managing the pain with holistic tools and managing the symptoms with holistic tools only at that stage. And after the dengue fever, it took me a good year to recover. And after that year, I was back in New Zealand. I flew to Christchurch over COVID 2020. A year before I had my surgery, when I would have been 32. I just turned 32. I had a severe flare-up where, again, all my joints swelled up. And at this stage, when I got back to New Zealand after having the dengue fever, I went into a bit of a desperation spiral of trying some really extreme diets, some extreme practices to try and heal, to try and, I guess, avoid the symptoms that none of us really want to be experiencing. And it got quite dangerous, and I ended up having a severe flare-up. And by this stage, I was just in a really tricky position where I wasn't on medication, and I couldn't start medication because the x-rays showed like severe bone on bone in both hips, but it also showed cysts in the bone in the pelvis, and bruising all down my thigh bones. I was in a lot of pain, and I was on crutches at this stage, unable to walk at all, unable to do much at all, really. My parents, I'd moved back in with my parents at this stage because I wasn't sure what was going on and what the future held and what I was going to have to do. But after having the x-rays and speaking to the rheumatologist and the surgeon, it was time for me to face the fact that, okay, I was going to need hip replacements to ever be able to walk again. And I was going to need both done. And again, it's a double whammy. It's hard to take at 32. It's like, why couldn't it just be one? But yeah, I ended up accepting this. I mean, it did take me a while. Again, denial. A lot of denial I've had in my journey, and I'll admit that I can see that clearly now. I didn't want to accept that this was the fate that I had, and that I had to walk it. But once I'd seen the x-rays and the MRIs where it showed the cysts and bruising and bone on bone, I was like, there isn't another way out for me except to have the surgery. So yeah, I opted to have both done at the same time after talking to my surgeon. Usually most surgeons, and I'll let Simon talk more about that, but most surgeons seem to only want to do one at a time, especially when you get older. But me being quite young and me already being on crutches and unable to do anything for myself, the surgeon was like, well, you're not even going to be able to rehab if we just do one, because you can't put any weight on the other. So for me and my situation, it was decided that both done at the same time was going to be most beneficial. Leading up to the surgery, I did have a few complications due to me doing the extreme dieting and the extreme practices. My bloods weren't optimal. I had very low hemoglobin, very low iron. I was anemic. And this just delayed the surgery because the surgeon didn't want to do it until I got my blood levels up. Fair enough, because I was about to go into quite a hefty surgery. So this took a while. I was 9 months on crutches before I could get to the surgery, which was hard, definitely, probably more mentally than it was physically. I mean, hard physically because you can't move, but mentally that grates on you. And I couldn't start any meds at this stage because I was about to go into surgery, and they don't often advise or like you to be on immunosuppressants going into surgery. But it was a bit of a double whammy, couldn't take anti-inflammatories because I got such a sensitive gut lining in my stomach from the years of being on anti-inflammatories when I was younger, and also being a bit reckless when I was younger. And so it was hard. It was a hard 9 months of just sitting in the pain and waiting. So when it came to the actual day of the surgery, I have to say the morning after surgery, I woke up in less pain than I'd been in prior to surgery, which is quite unheard of. But due to the mess that was my hips at the time, the surgeon wasn't surprised, and I wasn't surprised that I felt better immediately. And I'll read the questions in a minute. I can see a few coming in. But after the surgery, I have to say it is the best thing I've ever done. And I can speak more to the recovery as well, but I'm a year on now and it's like magic. I have to say this is the less pain I've been in since I was 10. So it's definitely a breath of fresh air, and I would highly say go for it for anyone waiting or trying to push that surgery out, because it is pretty life-changing. I'm just going to go to some of these questions while we're on it. Steroid injections, how many of those can you have and how often? I'm going to let Dr. Simon answer that one when he's on, because it's not in my medical field. But I can say that I had between 2 to 4 a year, and my rheumatologist at the time felt okay doing a maximum of 4 a year. But I know different rheumatologists and surgeons have different thoughts and ideas around that, but that's what I had. And what was done to bring the iron levels up and keep the levels up? Again, this is going to vary for a lot of people, but at the time I wasn't eating meat, and for me I switched back to a meat diet and got a lot of beetroots, dates. Yeah, that the surgeon was pretty clued on with nutrition, and I've got quite a lot of knowledge around nutrition, and I just looked up all of the really high iron foods in both vegetables and meat and just got as much of those into my diet as possible. And I think my mum at the time was making beetroot juice every day and making me drink it, much to my dismay. And then just before the surgery, I'd got it up to borderline levels, but they did give me an iron infusion just before the surgery so that I could recover a bit faster. In their medical opinion, they thought that would be the best course of action. Yeah, I had the surgery a year ago and I was on crutches. I was on 2 crutches for about 4 weeks. And I had the anterior approach. So my incisions were through the front. I don't think there's many surgeons in New Zealand that do that. I think at the time my one was the only one in the South Island, and after all my research I chose that approach because it seemed like a faster recovery time and no muscle had to be cut. So there's just 2 quite small incisions on the front of my hips. I'm actually quite surprised how small they are compared to how big the implant is. And the recovery time was pretty fast. So 4 weeks, I was on 2 crutches, and then I went down to 1 for 2 weeks, and then I came off both crutches at 6 weeks. Due to not having walked for 9 months or used any of my muscles, I had severe muscle atrophy. So my rehab program probably looked a lot different to what a normal rehab program would be, but for me I had to have a total body rehab program, and I had to put in about 2 hours a day I did it for a year because I like to go hard with things when I'm asked to do them, and I know it's my health in my hands. But it was quite extensive, starting off with physio for a couple of weeks, and then I got into the hydro pool once the scars had healed, and then I continued with daily physio, hydro pool sessions, physical therapy, and all sorts. I'm also a yoga teacher and functional movement teacher, so I had a lot of knowledge myself to be able to be doing the rehab, but I did work with a physiotherapist and some PTs as well, just to keep me motivated, because motivation during rehab, definitely I found that hard, turning up every day to do it, knowing that I had to do it every day in order to be able to like walk and move again, and it's definitely paid off. John asked, were you diagnosed with rheumatoid arthritis? So when I was 10, it was labeled juvenile idiopathic arthritis. When I was 18, they've been changing between diagnoses. I don't have set blood things showing in my blood, but they suspect it's either ankylosing spondylitis or psoriatic arthritis, and they're leaning more towards the psoriatic arthritis because I do get psoriasis as well. That's a little bit, that's a huge overview of what was a very long journey, but I'm going to leave space for questions because I think if I was the one waiting for surgery again, I'd want the space to just be able to ask questions and get answers.
So thanks, Natasha. That was a really great summary of what was a pretty long journey for you. I'm going to talk through a bit about what hip replacement is, and I'm going to come at it from a very surgical perspective. And I think one of the things that Natasha emphasized was what a long journey there can be before you get to the surgery, and how complicated and hard that can be. And I guess a point to make is that by the time you see a surgeon, you will have had a long journey, or should have had a long journey. And often surgeons are not very good at advice on all the things you want to do before surgery. The alternative things you might try, pain relief, exercise, those sort of things are often not well articulated by a surgeon. As Natasha sort of spoke about, there's often other practitioners who can give better advice on that. Surgeons are good at surgery, and I think in general we're less good at talking about the other options. So with that theme, I'm going to talk about what a hip replacement is and what's involved with that. But yeah, as Natasha sort of spoke about, I hope you realise there's an awful lot that can be done before you get to the point of needing surgery.
And on that point, if you do need advice on what can be done before surgery to help prepare yourself to recover as best you can and to strengthen the areas around where you need to have surgery, contact us. We've got lots of resources and information at Arthritis New Zealand on exercises and different things you can do to prepare yourself for surgery, because the wait time is essentially preparation time as well.
So this is a picture of a hip, and I haven't put many labels on it. I'll point here with the pointer showing the femur bone here, the hip or the pelvic bone here. An easy way to think about it is as a ball and a socket. But the key structure in arthritis is this coating, this light blue stuff here on the surface of the ball. That's articular cartilage, and think of it like the tread on your tires of your car, except instead of being grippy, it's nice and smooth. In fact, one of the smoothest substances known in nature. So wherever in the body two bones touch each other and have to move, it is smooth cartilage on smooth cartilage. The very bad news is that what you're born with is what you've got for life. So when that cartilage starts to wear out, that is what arthritis is, because your body does not have a mechanism to regrow that cartilage. And despite decades of research and hundreds of millions of dollars thrown at this problem, no one has yet come up with a way to make that cartilage grow back. All forms of arthritis share in common that articular cartilage is damaged. The most common cause is osteoarthritis, and that's a wear and tear phenomenon, so it happens more often when you age. Whether you get it or not is a combination of your genes and also injuries or things that may have happened to you during your lifetime. There are lots of other forms of arthritis, the inflammatory ones such as rheumatoid, and what Natasha described are where your body's immune system is attacking the joints and attacking the cartilage when it shouldn't be. Those are much better treated now than they used to be historically with medication. So as surgeons, we now do far, far less hip replacements and knee replacements for inflammatory arthritis such as rheumatoid or what Natasha's been through, because the rheumatologists are much better at treating these with the medications, so they get to stop it before the joint gets destroyed. When you get that sort of inflammatory arthritis, like when you're very young, like Natasha had, that is a much harder proposition to try and control with the medications, because people have got so much longer to try and manage it. So inflammatory arthritis, which getting that when you're young, like Natasha, that's still really an unsolved problem in medicine. But whatever the kind of arthritis, the end result is the same, is that articular cartilage is worn away, just like the tires in your car going bald. And that manifests with pain, with stiffness, but also with other things that are a bit harder to define, like muscle weakness, reduced energy levels, and poor exercise tolerance. It really isn't just a sore joint. It can be symptoms that you experience right through your whole body. It's also pretty tough on your mood. And again, Natasha gave a good description of that. Like, chronic pain is very hard to deal with. And it's not until you have it that you realize how hard it is. And it takes a toll mentally. And so I think part of the care for this when you're managing arthritis is not just thinking about the joint, but also thinking about your own well-being. As if you're waiting a long time for a hip replacement, as many people in New Zealand are now, it's a pretty tough thing to do, to live with chronic pain. The x-rays, what we look at when we're assessing someone with an x-ray is for this joint space. So if you look here on the ball here, or the femur, and the socket here, you can see a gap between the two bones. And that gap's not really a gap at all, but the x-ray beam goes straight through the cartilage. So while we can't see that coating of cartilage, we can tell how much is there by the size of the gap. And when you get arthritis, that gets narrow. And in this case, it's gotten so narrow that you can see the bone rubbing on the bone. There's a few other things that happen to go along with that. Your body can't grow new cartilage, but it can grow extra bone. So you get these little bits of bone growing at the side. We call them osteophytes. And because you've lost the tread on your tires, if you like, the bone underneath starts to wear and get cysts inside it as well. So we see these changes. So this is sort of quite an extreme version of arthritis. When you've got inflammatory arthritis, you can also see quite a lot of erosions as your body's immune system doesn't just attack the cartilage, it also starts to attack the bone. So a hip replacement can be simply thought of as a new set of tires. So what we do is resurface the socket by putting a cup in place, and then removing the head of the bone and replacing it with a metal prosthesis that fits into the bone with a ball and socket joint. And this articulation, especially in the hip, is very good at simulating the native joint. A little bit harder in the knee because the joint's more complex, but the hip really is just a simple ball and socket joint. So the biomechanics of it are actually relatively easy to recreate with an artificial joint. I'm going to show some pictures now. I'm just going to give you a warning if you don't want to look at them. There's some pictures of an operation where you'll see inside somebody's hip. So I'm just giving you a bit of warning if you don't want to see what the inside of somebody's hip looks like. So in the next picture, I'm going to show where we've made a cut to remove the ball, and you'll see the surface is worn out. So just giving you the warning now. So on the left here, this is looking inside the hip joint, and here is the cut that's been made across the top of the femur bone, and here is the head that's been removed. And you can sort of see if that was a young, healthy head, you'd see a bright, shiny, articular cartilage. Instead, you're seeing something that's very worn. It should be bright, smooth, sort of glossy, articular cartilage that you're seeing there, rather than this very worn-out hip. So after doing this, the socket is here, and the next picture will show that socket being what we call reamed. So you get a circular reamer and ream out the bone. So you've created a space for a new cup to go in. And the cup that we put in is made of metal. The shell here on the coating has got a special coating so that your bone will grow into it. We call that uncemented fixation. Another way to put the cup in or the stem in is by using cement to hold it in place. But in this setting, the coating on the cup allows the bone to grow into it. These little holes here are in case the initial press fit is not stable, and we put little screws in to hold the cup in place so it's stable while that bone grows into it. We then put a liner in, and the liner can be made of various different things. This is something called ceramic, which is nice and hard. Another common alternative is polyethylene, which is a high-density sort of plastic that we use. The advantage of the ceramic liner is that it's very hard wearing, so in younger patients, they may be more likely to get a ceramic hip. The slight downside is that if you put a ceramic socket and a ceramic head, there's a small number of people who will get noticeable squeaking, which is disappointing if you've just had your hip replaced. It's pretty rare, but it is an issue. So the most common hip that goes in New Zealand would be a polyethylene liner, and then either a metal or ceramic head. Looking at this back out to sort of see how you would view it, you can see the shell, the metal shell here around the outside, sitting in the bone with the rough surface so that the bone will grow into it. You can see the polyethylene liner, the white liner here, and then the ceramic head. The head is then attached to a stem, which actually goes into the bone. So if you're looking into the bone, it goes down on the inside. And that's the most common form of hip replacement. There are some other variants of resurfacing, but this is the most common form, where you put the stem inside the femur bone, the cup inside the acetabular bone, and then have a bearing surface in between. Post-operatively, this is ready to go. Like, we try to have people up on walking on it straight away. And most people now are up the same day after their hip surgery. It can be done even as a day-stay procedure, though in New Zealand, most commonly people will stay in hospital for 1 or 2 nights. But the trend worldwide is for people to try and get out of hospital quicker. The last slide I'll show is just what people commonly ask, how long they last. And the idea is that they will last as long as you do. So a better way of thinking about whether the hip will last 10 years or 15 years is to think, what is the chance that this hip will last the rest of my life? And the key thing to that is how old you are when you have one. But everybody who has a hip replacement put in, the goal is for it to last forever. If you're in your 70s or your 80s or 90s, obviously, not only do you have less time that it's likely to have to last, but also what you'll do on your hip when you're in your 80s is not as much as what you would do on your hip in your 40s. So you get more wear when you have the hip younger. So this graph is showing the lifetime risk of revision. Revision means changing it, so needing to have another operation to change it. And so somebody who has a hip replacement when they're in their 80s, it's about a 95% chance that it won't need changing for any reason. Whereas somebody who has a hip replacement in their 40s or 50s, there's around a 70 to 75% chance it would last their whole life. So still, by far and away, the most likely thing is that it will last the rest of your life. But the younger you are that you have it, the more likelihood is that it might need changing at some point.
Thank you so much for that. We actually had an email in before the event from Judith, and she said that she's had her left hip replaced and there was no pain. But 2 years ago, she had the right replaced and she never became pain-free. So, and it has difficulty walking still. So her question is what's gone wrong? So why such a difference? I'm sure there's like a lot of reasons for an individual.
There's a lot of reasons, right? Yeah, I mean, that would sort of require seeing you and examining your hip and looking at your x-rays. There's a number of possible reasons why your hip is still sore. It may be that there's actually something wrong with the implant. The first thing people would think of when they saw you with a painful hip would be to rule out an infection as the cause. But there may also be some other non-hip reason that you have pain around the hip. One of the hard things with hip pain is that people refer to their hip when they can point to quite different parts of their body. Most people who have pain from arthritis in the hip joint, the most common place that you feel it is in your groin, whereas people will often point to the side of the hip or their buttock or their lower back and say, it's my hip that's sore. So all those things sites of pain can be from different reasons, such as a bursitis from muscle pain or even referred pain from your back. And referred pain is one of the hardest ones because some people have a hip arthritis, but the pain they experience referred to their knee. And some people have only knee pain, despite the hip being the problem. And there's been cases where people have had their knee replaced and woken up with still exactly the same knee pain that they had before, and then gone on to have their hip replacement and their knee pain is gone.
Oh, yeah.
So the reason why an artificial hip's still sore, there's a ton of reasons, and all I could say is that you sort of need that to be assessed by your hip surgeon for them to look through the sort of common reasons and see if they can help you. But that's not something you should try to or have to live with. Like the goal really is to get to the bottom of why you got pain and try to solve it.
Yeah. Awesome. Thank you for that. And Ellen has asked about steroid injections. Is there a certain amount that you can have per year, or is it case by case? The concern with steroid injections is that over multiple injections may have a negative effect on the cartilage. So if you have lots of steroid injections, the concern is that it will make your hip wear out faster. So how many and how often, no one really knows. What is commonly quoted is having 1 or 2 injections. No one's really sort of worried about that, but you would try to have at least sort of 3 months between the injections. If you were needing 2, 3, 4 injections, then most people will be thinking, well, that's an indication to do something surgically. If you're very young, then the surgery is less attractive because, if you have a hip replacement when you're in your 20s or 30s, there's a really high chance that it won't last your whole life and need replacing. So if in that sort of situation, you may push that a little bit more and do more injections and do them more frequently, but still at least sort of 3 months between injections is commonly quoted. And most people, I think, would be preferring not to do more than 2 or 3 a year. But you'll get different advice on that. The evidence on it is pretty weak, and most people have an opinion, but it's not really backed up by much data. And Jean has asked, so we are told there is a risk of dislocation because of some activities, e.g. some yoga poses, crossing your legs, etc. Are there particular movement restrictions and dislocation risk for the rest of your life?
The answer is yes, but there's a few different aspects to that. And I thought of talking about that, but it's quite specific to the hip replacement that you have and to the individual, and also the surgical approach you have. So there's different ways of putting the hip replacement in. You can come through the front of the hip and split muscles to do that, or you can go in from the side or from the back of the hip. And the dislocation risk is different depending on which approach you've had. So if you've had an anterior approach or coming from the front, the hip is more likely to dislocate out the front. And so the positions that you should avoid are different than if you had a hip replacement that's gone in through the back. Generally, trying to keep your hip, your knee, and your ankle all pointing in the same direction when you're moving in bed is the guideline, but there's a little bit more to it than that. And I think it's kind of something that gets explained to you when you're having a hip replacement, and depending on what kind of approach you've had. For people who have very high risk of dislocation because of the things that they do, so say a young sports person who's having a hip replacement, or somebody like you say who's into yoga where you're putting your hip into extreme positions, there are some different types of implants that we can use that have a lower dislocation risk. And typically those are the ones with a bigger head, because it's harder for a big head to come out of a socket than a smaller one. And one variant of that is called a hip resurfacing, which is where rather than cutting the head off, you actually keep the head there and put a new coating on the top of it. And yeah, that's a variant. It's a little bit more technically challenging, and there are some other negatives to that as well. But the individual dislocation risk and what you need to do to avoid it is something that you sort of need to discuss with your surgeon, because there's a few different factors that go into that.
And Suzanne has asked, does having lupus have adverse effects on hip replacements?
No, it's lupus in itself. When you have an immune condition, the concern is that there might be an increase in infection either because of the condition or because of the medications that you're on. I would say that we're better at preventing infection than we have been at the past. It was the topic of my PhD was on preventing infection in knee replacement, and the rate now is very low. So infection-wise, it's a problem when you have an artificial joint, because you've got a foreign body in the joint. So it's like having a splinter in your finger. If it gets infected, the best way to get rid of the infection is to take the splinter out, because the bugs stick to the surface of the splinter, and your body's immune system, antibiotics, can't get to the splinter because it doesn't have a blood flow. And it's a little bit like that if you get an infection around a hip or a knee replacement, that often the only way to clear the infection is to take out the implants, wash everything, clear the infection, and then put new ones back in again. So the reason we talk about it and worry about infection is not because it's common, it's uncommon, but because if it does happen, it's a big problem. And so with things like lupus or rheumatoid arthritis, there is a slightly higher infection risk, but with lupus in particular, it's not hugely increased. So there might be a little bit more planning about which medications you're on and things like that, but no, lupus is not a contraindication, or you can still do a hip replacement in somebody with lupus.
And we have someone asking about your thoughts on hip resurfacing versus total hip replacement. 30-year-old male here with advanced arthritis in his hip, and he says, unfortunately, too far gone for a hip arthroscopy.
Arthroscopy, yeah. That's hip resurfacing is where rather than taking the ball off completely, you resurface it. I've got a picture here. You can sort of see here's the same ball that we were talking about before. So this is what goes into the socket. You can see the uncemented coating there. But instead of cutting the ball off and then putting in a new stem down it, what you do here is put this metal shell over the top of the old hip. So in effect, what you're doing here is getting a very large ball, and these very large balls are less likely to dislocate. And this sort of came in around 10 years ago. Because the ball is so big, or you're just resurfacing it, you can't use polyethylene or ceramic, because when you make polyethylene or ceramic very thin, it becomes very brittle. So that means that both the socket and the head have to be made of metal. And that's fine. You can have metal articulation. It's like a ball bearing with metal articulating with metal. But one of the issues, because when this came out with one company producing it and the results seemed to be quite good, then multiple other companies came out and the engineering wasn't quite as good. And what happened is their metal on metal surfaces started to decay, and a lot of people got into a lot of trouble because of the metal on metal hip replacements. What's then happened is most people have moved away from doing metal on metal hip replacements because of this problem, but the original hip resurfacing still works. It's called, the other name for it is Birmingham, because that's where it was developed. And it's still a viable option. It probably works best in young males, and that's probably the group that is still advocated for. Some of the advantages are that you keep more of your own bone. It's a bigger socket, so it's less likely to dislocate. So if you're a sportsman who might be falling or twisting or things like that, where you're getting your hip into extreme positions, then having this larger head with resurfacing might be advantageous. So some famous sports people have had that resurfacing recently, like Andy Murray. But it does have some small disadvantage of that metal on metal. But the results in young males tend to be really good. Also, the results, though, of other hip replacements in young people are also very good. So it depends a bit on the surgeon. I don't think there's a right or wrong decision here. It is something that you want to discuss specifically with your surgeon. I would say if you're interested in that, you should speak to a surgeon who does hip resurfacing, because all surgeons who do hip resurfacing also do other forms of hip replacement. Whereas if you see a surgeon who doesn't do hip resurfacing, they're less likely to talk to you positively about that as an option. And there's 2 or 3 people in Auckland, I'm not sure where you're from, there's some other names around New Zealand.
Why is it successful in males? Is that just because males are more likely to play sports and that's where it's successful? Would it be a similar rate in female athletes?
Partly that, partly also when you have these metal on metal hips, if you do a blood test, you have very high chromium ions. Because the metal, the best metal for polishing and joint replacement is an alloy of cobalt chrome. So that shiny metal, it looks like stainless steel, but it's actually made of cobalt chrome alloy. And because you've got very small amount of wear happening all the time, when you've got an artificial hip that's got a metal on metal bearing surface, you'll have chromium and cobalt ions that are high in your blood. And no one really knows if that's harmful. We think it's probably not. The obvious thing is cancer, and people worry about that. But the long-term follow-up hasn't really shown any risk. But for women of childbearing age, that's kind of another risk, right? Because you don't know if these have any effect on a fetus. So that's one reason why people who are of childbearing age, you might be less inclined to want a metal on metal hip. The other reason is as people get older, their bones get thinner, and especially in females. And because with this hip resurfacing, you've kept that femoral neck. That femoral neck is a common site of fracture when people get older. And that means that if you've had a hip resurfacing, say when you're 40 or 50, and then you get older and you're female and get osteoporosis, if you fall over, you're more likely to fracture through that femoral neck. So that's the other reason, that because in males are less likely to get osteoporosis when they're older. So they're almost better off not having their femoral neck there. This is sort of what I mean there by that neck, where that narrowing of the neck is a commonly fractured. So when you have a hip resurfacing, you keep your neck. It's just the resurfacing of the ball or the socket. Whereas when you have a hip replacement, that neck is actually cut. You cut that neck off and put a new ball on, so you can't fracture it anymore. So that's the main difference, the main reason is common in females.
This person is in their 30s and they have a hip replacement next year. They love running and run between 25 to 40 kilometers per week on a treadmill with a harness that takes 20 kilos of body weight off. They also do half marathons on their setup from time to time. Does running cause excessive wear and tear on implants? Should I look to switch to cycling? Thanks.
Most surgeons would probably tell you the answer is yes, that running is likely to cause more wear, and therefore you're more likely to wear your hip out if you keep running. I will say that no one really knows that for sure. And what's tended to happen when we started doing hip and knee replacements in the 70s and 80s, we told people they weren't allowed to do anything. They could walk and not much else, including cycling. But what's happened is that people have got lots of hip replacements and got lots of knee replacements, and then they just go out and don't listen to their doctor and do whatever they want. And we've now seen a lot of people who have run on hip replacements, less so on knee replacements. So it's usually people with knee replacements are less likely to be able to run. But people do it on hips, and we don't really have a lot of data to show that they're more likely to wear out. So I think if you talk to most surgeons, they would advise you, yes, it's probably a better idea to switch to cycling. If you didn't and you carried on running, especially with your load off, reducing the load that you were doing on it, I think you probably are increasing your risk of wearing it out a bit. But it's when you're 30 and if it's what you do and love doing, I don't know that it's completely crazy to be doing that. Yeah. If it's not painful, you're probably, if it's causing you pain, you probably definitely shouldn't be doing it. But if you're able to manage, I'd chat about it with your hip surgeon. And again, they might do something different with the bearing surface, which might tolerate it. I think certainly with the hard bearing surfaces like that resurfacing, which is metal on metal, or the ceramic on ceramic, those are a little bit more durable and perhaps can cope with activities such as running better than the polyethylene. But again, a lot of that's just theory.
Suzanne asked, can you take immune suppressants before hip surgery?
You chat to your rheumatologist. Yeah. We used to stop a lot of them. Now we actually keep most of them going, but it depends a bit on which one you're on.
Falcone asks, when would you choose a total hip versus a partial hip replacement for an inflammatory hip arthritis?
If he's meaning a hemiarthroplasty, that's where you replace the ball but not the socket. The main reason we do that is if somebody has fallen over and broken that femoral neck, so that the ball has fallen off, and they don't have arthritis, all they've had is a fracture, so just the ball has come off. So we just put a new ball in, and it articulates with their own socket. That would be very uncommon to do in any other situation, especially inflammatory arthritis, because if you've got a half hip replacement articulating with your own socket, if you've got inflammatory arthritis, your own socket is actually a little bit soft because the inflammation has made their cartilage and your bone a bit weaker, so the ball can actually erode into it. So I think that's what you'll be talking about, and yeah, unless it's a fracture, I'm pretty certain your hip surgeon will be telling you to have a full hip replacement.
All right. And Tui's asking, what is the weight requirement for a double hip replacement?
It's mainly anesthetic, so it's not an absolute requirement for the weight, but if you think of having one hip replacement, it's a stress on your body, it's a stress on your heart, it's a stress on your lungs, so you've got to have enough reserve to be able to cope with it. If you're then having two hip replacements at the same time, then you've got to have even more reserve for your body to cope with it. So things that decrease your reserve are things like having a high body mass or body mass index. And that's a little bit depending on the person, because somebody who's 6'6" and 120 kilos may be quite lean and fit, whereas somebody who's sort of 5 foot and the same weight won't be, right? So it's more about your general health and your heart health, your lung health, and it's fairly individual. So while some people do put hard numbers on that, so say a body mass index of 40 is something that's commonly quoted, people won't do bilateral hip replacements if the body mass index or BMI is greater than 40. Really, you need to individualize it and chat to your surgeon. The main advantage of having two at the same time is just that you only have to go through the recovery once. Natasha's was a slightly special case because she was, I haven't seen her x-rays, but she was really struggling with both hips, so it would have been hard for her to do the rehab on one hip while the other one was still so arthritic. For most people who are older and having hip replacement for arthritis, the main reason to do them both at the same time is for people who are working and they don't want to take the time off work. Builders who self-employed people who can't afford to be off twice, then the attraction of doing it all at once is appealing.
Cool. Someone else has asked, is there like a maximum number of hip replacements that you can have in your lifetime?
No, definitely not. No, I've seen people who are into double digits of the hip replacements they've had. Wow. But if you're into double digits, then it's not been a good story, I promise you. And somewhere along the way, there will have been an infection or a fracture or something gone wrong. But as I say, even people who are very young nowadays, we are trying to put in one implant that'll last the rest of your life. And the bearing surfaces and things that we have are now at the point where it's uncommon for them to fail because they've worn out. If they fail, it's usually because of things such as infection or fracture or dislocation, those sort of things, rather than wear of the components.
A couple of questions about hip resurfacing. Is it available in New Zealand, and can it be done in the public hospital system?
Yes, and yes is the answer. So yes, it can. It's quite surgeon dependent. So Not all hip surgeons do resurfacing, and which is actually a good thing, because it's a bit more technical. And the reason it's technical is that to get into the hip joint, if you imagine you've got a ball and a socket, if you're going to cut the ball off, it's quite easy to then get into the hip. Whereas if you're going to try and keep the ball, you have to release all the muscles around it, and it's much more technical to get the hip out of the place. So it's a bigger incision, a longer operation, and it's just a bit technically harder to get the ball out and then put it back in again without making that cut. So it's better that that skill set is narrowed down, so that the way to get good at something is to do lots of it. So because there's not as many hip resurfacings done as hip replacements, it's better if that skill set is limited to a smaller number of surgeons. So it's going to depend on the centre, but I would say that most centres, bigger public hospitals in New Zealand, will have a hip surgeon who does resurfacing. There's been a bit, because when it first came out, there was kind of a wave of everyone thinking hip resurfacing is great. Everyone, and so lots of people were doing it, and then the metal problem happened, and that really made it dive right away. And also the other kinds of hip replacements got good, so they got better. So the advantages of the resurfacing over a conventional hip replacement became less clear. So now the indications for doing a hip resurfacing are more limited. So I don't want you to think that like if you don't have a hip resurfacing, or you've been advised not to do that, or your surgeon doesn't do it, that you're missing out too much. I definitely don't think that's the case.
Thank you. And Sue asks, is it possible to have an allergic reaction to the materials used in the replacement?
Really controversial, that. So lots of surgeons don't believe that allergy to artificial joints, the material that we use, exists. It's a problem because there's many people who have particularly knee replacements that are painful, and we don't know why. It's less common with hips, but it also does occur. And we look for reasons such as infection, referred pain, or muscle pain, and do all these tests and come up with nothing, and the hips or knee is still painful and we're not sure why. And so allergy is something that when you hear that idea, patients often, everyone understands allergy, right? I must be allergic to the metal. But there's been a lot of research in that area, and people who are, say, sensitive to nickel on their skin, doesn't seem to be, being skin sensitive to something doesn't seem to matter when that component is inside your body as much. So I don't want to say that it doesn't exist, or no one in the world is allergic to the artificial joint they've had put in. But the evidence on it is, and just there's a lot of research on it, is not very convincing. And so I think if it does exist, it's an uncommon cause for pain. There are some forms of prosthesis that don't have things like nickel in them, that are specifically marketed as non-allergenic. But the results of those prostheses tend to be slightly worse than the other prostheses. So allergy to those components seems to be an uncommon issue, if at all.
Are there any stats on whether hip pain post-surgery is more common in the second replacement rather than the first?
I haven't seen any stats on that. No. The outcomes of first versus second, or left versus right, has been looked at, and no sort of correlation. I think you're as likely to have persistent pain in your first hip or your second hip, or your left hip or your right hip. But to give some numbers on that, so around sort of 10% of people who've had a knee replacement will have some degree of dissatisfaction, in that they didn't think it's not as good as they wanted to. Sometimes it's higher, 20%, but it's a little bit less than that. In the hip, it's only around 4 or 5%. So most people with a hip replacement have little to no pain afterwards. But if you're in that group, then that 5%, it can be really frustrating. And I'd encourage you to sort of make sure you're getting all possibilities of why you've still got hip pain looked at.
That actually leads perfectly into the next question. Heather's asking, she's had a left hip replaced and 2 years later fell off her e-bike, and she's had pain ever since. Surgeon's done an MRI and said nothing is wrong. So what would be her next step? I
would get another opinion. Yeah, that's probably what you have to do. Yeah. And you can do that in the public system as well. Generally, you don't even have to tell the surgeon that you're seeing. You can just ask, can I see somebody else? And even if you're in the clinic of that person, seeing them, most surgeons are understanding, and certainly if somebody said, "Can I see someone else?" I'd have wouldn't be even slightly offended. None of us know everything, and you look at a problem when a patient comes in and you've never seen them before. You're looking with a fresh slate, and I think if surgeons spent the time and effort of putting an artificial hip in you, they've got some sort of preconceived ideas about it, I guess. They've already invested time and effort in trying to make your hip better, and it's often as disappointing for them that you've still got pain as it can be for you, right? So I think it is good to have a fresh set of eyes on that if you're not getting good answers from one person. Even if it's just to say that hear somebody else say, "Look, we don't know what's going on," then you've at least got that reassurance.
Thank you for that. That's such a great answer. I know a lot of our community are really appreciative of their surgeries and don't want to offend their surgeon by getting a second opinion, or think, "Oh, that's so rude and disrespectful of me because you've been looking after me and now I'm going elsewhere." So it's really nice to hear that it's just kind of a professional thing that you can just do, and it's not a problem.
Yeah, so I think most surgeons wouldn't be offended if you asked, and or if you did it and they found out. It's not something that people get upset about, but it happens all the time, and I think anyone who practices medicine, and especially orthopedic surgery, knows full well that they don't get it right every time.
Thank you. Someone is asking about surfing. They're an avid surfer. Is this something that is reasonable to expect to get back to after a hip replacement?
Yes. Yep, absolutely. Lots of people surf with hip replacements. Again, there's just these sort of more extreme sports. You have to think about the dislocation risk. So you would mention to your surgeon that you want to go back surfing, and they may do something different in the way they do the prosthesis to minimise that risk, either the approach or the size of the head. Just there are some technical things that do to try and minimise your risk of dislocation.
Cool. A similar question: cycling okay with a hip replacement?
Yeah, absolutely. Yeah, really good for your hip. People ski on hip replacements. Cycling, tennis, squash. People can be pretty active on an artificial hip.
And Ben is asking, are parts for a hip replacement generic or individualized? He's 6'11" and has a very long femur.
There's sizes. Yeah. So in rare settings, we do have custom implants, and it's usually in somebody with some unusual condition, say dwarfism, or somebody who's had previous fracture when they were a child and their hip has grown with some deformity. In that setting, we do have the ability to generate a specific custom implant that's 3D printed and specific for that one person. But if you're just really big or really small, mostly we've got sizes that fit that.
John is asking, is there any downside to continue to exercise the muscles that support joints when you've been diagnosed with osteoarthritis?
No. In fact, that's absolutely what you should be doing. Yeah. I mean, if any degree of arthritis, keeping yourself fit and strong is the number one thing to do. Keeping your weight down and keeping active. When there's not a very good correlation between how bad someone's arthritis is on their X-ray and how much pain they've got and how well they're functioning. And some people with terrible looking arthritis on their X-rays are running and still functioning well. And almost universally, those people with bad X-rays but reasonably good function are fit and not overweight and keep active. Yeah, that is if anyone's sort of telling you don't use it because you wear it out, that's the exact opposite. The key thing you should be trying to do is find an exercise that you can do without it hurting. Typically cycling, swimming, cross-trainer at the gym tend to be better tolerated than things like running or impact sports.
Everyone that calls us at Arthritis New Zealand, we help you find exercises that suit you and give you good evidence-based advice around what you can do to prevent further degradation or to lengthen the time of when you might need surgery. So give us a call, 0800 663 463. So Diane is asking that she felt like her legs were of a different length after her hip replacement. Is that a thing?
It's the thing. It's a definite thing.
Yeah.
It's less common in knee replacement. It's technically harder for us to change somebody's leg lengths. But yes, you can change someone's leg lengths with a hip replacement. All hip surgeons are aware of that and do their best to not change it. And the perception of a leg length difference is quite variable. Like everybody has slightly different leg lengths, just they're usually not exactly the same, often sort of 4 or 5 millimeters apart, but sometimes as much as a centimeter. So having a change after hip replacement, like say you were shorter on one side and the surgeons made you the same length, you might feel that you've had a change in leg length, even though you're now exactly the same, right? So that the perception can change. And most people who do notice a difference in leg lengths eventually get used to it. Sometimes people need to wear shoe raisers afterwards to make them feel more balanced. But a lot of it is also perceptive as well. So some people get really upset about this. It's a common cause of orthopedic surgeons being sued in the United States, is showing up, I've got a difference in leg lengths. And there's a lot of often emotion around it, thinking that somebody's made a mistake by making the leg longer or shorter. Typically, the length is set by getting the muscle tension right so that the hip is stable and not dislocating. So some people, the surgeon might choose to slightly lengthen it just because he's trying to make sure that the hip's not going to dislocate. But generally, they'll be trying to make sure that your leg lengths are the same.
Oh, thanks. So it's not an awful outcome if it does happen in terms of like future health outcomes or joint issues, is it?
A lot of it is temporary. Like it can be frustrating to feel that difference, and once you know about it as well, it's quite easy to focus on it. And what commonly happens is people come back and feel a difference in their leg lengths, and if they're still bothering it, say it's sort of 3 months or 6 months, they might try a shoe raise, and then wear a shoe raise for a while, and then kind of get used to it, and then not worry about it that much. There's a thought that it can also put a bit more stress on your lower back. So some people say it can go and cause lower back pain, but that's also sort of sometimes hard because lower back pain is really common as well, though it's not always due to a leg length discrepancy. But if you feel you've had a leg length discrepancy, then definitely tell your surgeon about it, and they'll be able to measure it on the X-rays, because it's not always easy to look and measure. You can get X-rays or scans that specifically check it, see if there is a difference, and if there is, the first thing you try would be a shoe raise to see if that made a difference. And if it was really an ongoing problem, you can reoperate. It's pretty rare to need to do that, but you could.
And there will be other allied health members that you could work with, maybe like physios or can you work with chiropractors after a joint replacement?
You're an orthopedic surgeon, because I guess there was sort of in that mainstream medical space, will tend to refer you more to a physiotherapist than a chiropractor. But if I see patients and they've had something work, be it a chiropractor or naturopath, if they've got pain that I can't help with, then I'm very encouraging for them to look at all options, because we don't understand all the causes for pain, and every practitioner you see will be sort of looking at your problem with their own skill set. So a surgeon's looking to see what operation can I do to help this problem. But not every problem needs an operation, and lots of practitioners have different skill sets, and as long as it's not causing harm or it's hugely expensive, then I encourage people to try things if they're not getting the results they wanted from a surgeon or a conventional practitioner.
Joanne's asking, what effect does osteoporosis have on hip replacement options?
One of the confusions here is that osteoporosis and osteoarthritis sound really similar, but they're quite different. So osteoarthritis is where the surface of the joint is worn out, and osteoporosis is just where the bone has gotten thinner. And an osteoporotic bone is just the same as a normal bone. It's just more likely to fracture if you fall on it. So osteoporosis doesn't mean you can't have a hip replacement or a knee replacement. You wouldn't have that hip resurfacing if you had osteoporosis, because you still got that neck, which is a vulnerable point in that bone. So really common thing is for older patients with osteoporosis to fall on their hip and fracture that femoral neck. But if you have a conventional hip replacement, we've already cut through that femoral neck, so it's not there anymore. You've got a new neck made of metal. So osteoporosis means that you're more likely, if you would fall over, to have a fracture of whatever bone, but it doesn't mean you can't have a hip replacement. If you do have a fracture around the hip replacement, that is a more challenging problem for us to solve, because you have a piece of metal inside a bone that's now broken, and putting that back together can be challenging. But again, that's a whole area that we're used to dealing with it. The phrase is periprosthetic fracture, and it just means that we use wires instead of screws and different techniques to get the fracture or put it back together when we need to. But that's sort of more our problem than yours.
And someone's asked, I'm not sure what this means. Is a game-ready cryo compression machine worth it after a hip replacement?
The evidence for hip is probably a little bit less, just because it's hard to get it all wrapped around the hip. I use it quite a bit in knees. They are reasonably expensive to rent. The studies on them show that objectively, when you're looking at people's pain scores and how much swelling they have, objectively, they actually don't seem to make much difference. But subjectively, and by that I mean if you ask somebody, did you like your game ready? People always say, yes, it was amazing. So they also look really quite cool. They've got a big, nice red bag, and they're quite convenient. So if they were free, I would give them to everyone. I think if you were going to spend, and I may be more for knees here, the hip, I'm less certain of the value with hips. If you're going to spend, I think they're like $300 to rent, any sort of thing extra on your knee replacement, I think a game ready is as good a thing as anything to spend it on. But equally, if you don't want to spend the $300 to rent one, I don't think you need to feel that you're missing out on something amazing. Regular ice works really well too.
We've had a couple of people actually say that they've got a heavy feeling around the hip area after having hip replacement surgery. This one person had their surgery about a year ago. So it feels fine, but they just have this heavy feeling and they're wondering what that could be.
I guess, yeah, it's hard to define the heavy feeling. I know what you mean. So it's the hip probably does, the metal probably does weigh slightly more than the bone that's been removed, but not that much more. You know, probably I doubt it's the weight of the implant that's contributing to that feeling. It's more likely scarring around the hip, you know, like a woodiness feeling. That means that it's just maybe not moving quite as freely, and you may have had maybe a little bit more scarring than average for no reason. You know, so there's a randomness to how people recover after surgery, and that might mean that your hip's a little bit stiffer at this stage. I would say that those sort of symptoms or that scarring phenomenon can improve like even out to 2 years post-surgery. So if you're feeling that at 1 year, those sort of, I guess, lower grade, the symptoms that are a bit hard to define, often in the second year can get better. It may be that, or maybe you just get used to it. Might be a bit of both.
What do you think of CBD oil for pain relief while waiting for a hip op?
Try it. Yeah. I mean, the focus with pain relief now is about different drugs that work in different ways. So rather than getting on morphine and just taking more and more and more, the idea would be to take a smaller amount of different kind of pain relief. So I often kind of think of it like a ladder with paracetamol at the bottom. And then the next is anti-inflammatories. And one you buy on the counter might be Nurofen, Voltaren, Celebrex. There's lots of different anti-inflammatories, but you take just one from that class. And then there's this next level, which is stronger things, like gabapentin, which comes at the nerves, tramadol, and then the morphine and morphine equivalents. And generally, you don't want to be up here. You'll be given a lot of these post-operatively, but you want to get down the ladder as quickly as you can, because the ones up here have the side effects, the dependence, and I mean it's been a huge problem in the US where they were sort of starting at the top of the ladder and just giving everybody this. Vicodin that you may have heard of and Percocet is paracetamol from the bottom of that ladder with the morphine from the top, and they were just giving it out at the same time. And it got into, it's been disastrous over there. Here in New Zealand, that never really happened. We've been pretty conservative with the stronger things, and most people will use tramadol, which is not quite as, I guess, dependent forming as the morphines. But I kind of think of CBD and other things that you might try as just coming in from the side of the ladder. And you know, if they work and help, and I don't think they're harmful. They're not commonly prescribed by people, but I don't think there's harm in doing it if you find it helps.
And Philip has asked, what is the best preparation for hip or knee surgery, maybe from 6 months out?
Oh, trying to keep as active as you can. Yeah, so the stronger your leg and the fitter you are going into surgery, the easier you'll find the rehab afterwards. That's often tough to do, right? Because the reason you're having a hip replacement is because you're sore. But if you can find an exercise you can do, like swimming or cycling, that even if you're just doing sort of 10 or 20 minutes a day to try and just keep that fitness up, keep that strength up, then you will get through the surgical episode better.
Awesome, thank you. And Deborah, along the same lines, she's waiting for her hip replacement operation at the moment, but she's in so much pain just recently that she finds it difficult to do any exercise. So should she push through the pain and keep exercising? She said the pain is so bad in her groin that it's very difficult to sleep.
Yeah, that's tough, right? Because as well, I'm saying the exercise, but if it's really sore while you're doing it, especially if it's like disrupting your sleep at night, that's yeah, it's hard to tell you to do that. Like in that setting, just try to get the hip replacement as quick as you can. If you're waiting in the public system, asking your GP to send another letter might help. It might not, but trying to do that. And I guess just trying to keep the pressure on so that to make sure that they're aware of how much pain you're in and suffering. If it's disrupting your sleep, if like exercising during the day was causing you to not be able to sleep at night, I'm not sure that that's a good trade. I think it's pretty tough to get through a day if you're not sleeping. If you're not on sort of maximal pain relief, then talking to your GP about other options of what you might need to do. Generally, we still try to stay away from things like morphine, but if you're on a wait list waiting for surgery, then that might be all you can try, or you might need to move up that pain relief ladder just to get you through until you have the surgery.
And we have a bit of a health system question here. Someone's waiting for their hip replacement and also another operation. They have to wait for the other operation to be done first. So if the hip op comes up first and you have to decline, do you get put back at the bottom of the list again?
No, you won't. You won't.
Oh, you won't.
No.
Okay.
They're largely independent, even if it's the same department, right? Like if you're on waiting for a hip replacement and waiting for a shoulder replacement, no, and especially now there's such a like political focus on the wait lists. When I first started at North Shore Hospital 10 years ago, we would see people and do their surgery within 2 months, 2 or 3 months. Currently, it's now about 12 months, and that's after seeing them in clinic. And often people are waiting a year from the referral from their GP to even make it to the clinic, and then another year to get to the surgery. I think that time's now being compressed. We're operating on Saturdays, and there's a real pressure on it to try and reduce that. But if you're on 2 different wait lists, then all that really matters now is the number of days you've been waiting. That's what there's a lot of pressure on managers to make sure that people are being done in order. So unless there's a medical reason, like which happens, right? If somebody's on a wait list for a year, they might have a heart problem or something new that they have to be delayed. Unless there's a reason like that, then people will be trying to do you in order.
Yeah, I think that's what this anonymous person is saying, that she had to decline the hip op because she was getting another operation. So does that mean she goes right back to the bottom, or does she stay?
She won't go to the back. No.
She won't go to the bottom.
No, in fact, quite the opposite, right? Because she'll start to, her number of days waiting for a hip replacement will start to tick up, and she'll start to end up on a manager's desk. And all the managers are under pressure if somebody's waiting more than a year for their surgery. In that setting, if you might be suspended from the wait list if there was another medical reason why you couldn't do it, but you won't go back to the start of the list.
So James is asking, he's 53, he's had RA since 18, had a left hip replacement 27 years ago and right hip 21 years ago. What are the expected life cycle of first time and revision hip replacement surgery? Yeah,
I don't know how old you are now, but 27 years is a long time, particularly because the hips that they were putting in 27 years ago maybe weren't quite as, the materials and the polyethylenes maybe weren't quite as advanced as they are now, but they were still pretty good. So I wouldn't worry. If it's not sore, I wouldn't do anything about it. But if you did start to get symptoms of any kind, or even if you haven't had an x-ray for 15 years, I would get your GP to take an x-ray just to check on how they are, and especially if you've got any symptoms, because sometimes, especially with the older hips, they can start to wear, and it's harder for us to do the revision. But if you lose bone as well, if they're starting to wear away. But if you did need to have a revision, and hopefully you won't, then you would expect the revision to last the rest of your life. Nowadays, it's not that they last 10 years or 15 years, but we're aiming to do one operation, and that to be it.
Someone's asking which hip surgeons are recommended in the Christchurch region.
There's a few. I mean, I know orthopaedic surgery is pretty small in New Zealand, so I know of everyone, but I don't work in Christchurch. I think in general you want somebody who's doing a lot of them. I think that's true for most surgeries. If the more you do of it, the more the better you get at them, the more consistent you get, and the more experience you have at it. So I think it's good to see someone who specialises in hips. But there's a lot of really good surgeons in Christchurch. Christchurch's got a really good orthopaedic department, so I think it'd actually be hard for you to go wrong there.
I really want to thank you both for being here so much. This was great for our community and awesome for us to learn a bit more too. So yeah, kia ora Simon, kia ora Natasha.
Kia ora, Tracy. Thank you. Thanks,
Yeah,
Simon.
kia ora. Thanks, Natasha, for sharing the story. That was really, really great.